Chairperson, for the kind introduction. Thank you, Dr. Ashutosh and Pallavi ji, for giving me opportunity every year and year, for every time a new topic. Although I have discussed and I have talked on the gestational diabetes before also. But this time I am going to talk absolutely a new thing about the gestational diabetes. What I am going to talk, now I'm not going to talk you today about how to manage the GDM, how to use the insulin, and how to diagnose and how to screen. The only thing what I am going to tell you today, how can we prevent the diabetes mellitus pandemic in our country by creating awareness for the gestational diabetes. And that is the most scientific thing what we can discuss today, because this is the way through which we can reverse the diabetes pandemic, what we are going to face. As our chairperson has very rightly said, every day we are getting, not only in females, but also in males also, the people are eating and eating, but not taking care of their physical activity at all. And we are just gaining the weight. Everything we are gaining, but we are losing our health. So for that reason, this is very much important. How can we really reverse our diabetes? Now I'm coming to share my PPT. Hope it is visible to all of you. Kindly confirm.
Yes.
Okay.
Go ahead, Anuj. Go ahead.
Thank you, Dr. Varesh. And so in the next 20 minutes, I shall be talking with you that gestational diabetes, how does it provide a window of opportunity for diabetes reversal? Yesterday was the GDM day, National GDM Day. It has been declared by Government of India as a GDM day because yesterday was the birthday of Professor V. Sheshia, who has really for the first time created a awareness regarding the gestational diabetes. And you would be very happy to know that the gestational diabetes guidelines has also been popular in our neighboring countries, and these are the guidelines which have been given the approval by Government of India also to be used at each and every level of care, may it be at primary healthcare center or tertiary healthcare center. So on yesterday was the gestational diabetes day, GDM day. So I requested Dr. Ashutosh to switch my topic over the GDM and how does it can contribute in the reversal of the diabetes. This is the trajectory of diabetes of last 20 years. You must be looking over this. This is a sharp shooting rise in the diabetes population since from the 2017. Do we really have any answer of this? Is there any hope of reversal of this trend? If yes, what should be the focus of our efforts? How should we get it done to be reversed? Let's take you to the hypothesis which has been given by David Barker. David Barker has said that body susceptibility to lifestyle disease is programmed intrauterine. What we could understand little later. What we really see a phenotype of a human being, it is is it decided by genetics only or something else also which is having an influence over this phenotype? Of course, the genetics is having a big influence on the phenotype, what we have on our disease pattern, what we have. But apart from that, the intrauterine environment, at the same time, the postnatal environment, what we can see that our lifestyle, where we can see our lack of the physical activity, lack of the exercise, luxuriousness, and dietary pattern, all these contribute to the very important part that is called as epigenetics. So this epigenetics sometimes over-dominates the genetics. So what has been said by the Barker that genetics loads the gun, but the environment that triggers the gun. That if there will not be a trigger, even if the gun is loaded, it will not be able to fire. So this should always be kept in mind that more important are the environmental factors than to the genetics. You can understand that genetics of our forefathers, our ancestors were also the same what we are having. but they were not so much diabetes were carrying. They were not so much of the lifestyle diseases were carrying. They were not so much non-communicable diseases were they carrying, but we are. So this is something which is the epigenetical environmental factors which are having the trigger in their hand and they are causing it. Let's talk about these triggers. The most important trigger is the hyperglycemia during the pregnancy, especially the hyperglycemia which is occurring at the time of the fetal development, at the time of the organogenesis, that changes the structure, physiology, and metabolism, which predispose individuals to the disease in the adult life. So all you will agree with the hypothesis of the David Barker now after many, many years, that fetal origin of the adult diseases. So when we take this hyperglycemia in the pregnancy, which is commonly known as the HIP, but sometimes it is gestational diabetes when it is for the first time diagnosed in the current pregnancy, and it actually represents the detection of chronic beta cell dysfunction. This is the most concerned thought, and this is the most concerned reality also, that gestational diabetes is the point where we can identify a woman who is having a chronic beta cell dysfunction, and probably she will be diabetic in the next few years, because her pancreas is not capable enough to take the challenge of continuously increasing insulin resistance of the pregnancy, because of what the hyperglycemia has arisen during the pregnancy. That's why it is called that gestational diabetes is a stage in the evolution of type 2 diabetes mellitus. So that's why we say that women with a history of GDM are at increased risk of the future diabetes, predominantly type 2 diabetes, as are their children. So there are the two generations which are on the stake of diabetes. One is the present generation, the mother, and in the next generation, may it be male or female, whatever the offspring is coming up, he is having a risk of getting diabetes. So this is a transgeneration transmission of lifestyle diseases, type 2 diabetes takes place. How does it happen? What is the mechanism of this? Another hypothesis of the fuel of nutrients. Nutrients which works as a fuel during pregnancy, especially in the maternal body. And this hypothesis has been promoted by the Norbert Frankel. Fuel-mediated teratogenesis. What is the fuel? Fuel is the glucose. When this glucose is not utilized by the mother, obviously it will be utilized by the fetal pancreas. And what does fetal pancreas will do? It will help, or it will contribute in the weight gain or multiple changes in the body of the forthcoming offspring. So targeting intervention early in pregnancy beyond glucose may be critical to improve fetal growth pattern. Let's talk about how does it happen. Whenever there is a hyperglycemia in the pregnancy, we understand that glucose can cross the placenta, but insulin cannot cross the placenta. In the response of the maternal glucose, maternal pancreas reacts in the form of the insulin secretion, but this insulin can be utilized by the mother only. This insulin does not cross the placenta to enter into the fetal body. But once this glucose crosses the placenta and fetal organogenesis has already been done, then fetal pancreas is started stimulated by this maternal glucose which is crossing the placenta, and this fetal pancreas starts secreting more and more insulin. For that reason, this child starts gaining the weight, lot of fat deposition starts taking place, and now it comes into the habit of secreting more and more insulin. Because of what? Its exhaustion of the pancreas process has started in the pregnancy only, in the gestational time only, and apart from that, whenever the neonate takes birth, it remains into the recurrent hypoglycemia and other complications. So recurrent hypoglycemia or neonatal hypoglycemia is the first complication of the gestational diabetes, in which diabetes is not kept under control by the mother. What the others can happen? If the child is male, then he can develop the obesity or impaired glucose tolerance and ultimately ends up with a diabetes. If the female, then obviously she will be having these two risk of getting obese or getting diabetes or getting cardiovascular adverse outcome, but at the same time, she will be on the higher risk of getting the gestational diabetes. So this becomes a vicious cycle that pregnancy and that hyperglycemia in the pregnancy is giving rise to the gestational diabetes in the future generation of the females, as well as in the diabetes and obesity in the male gen next. Across the maternal glucose spectrum, exposure to the higher levels in the utero is significantly associated with childhood glucose and insulin resistance, which is independent of maternal and childhood BMI and family history of diabetes. So apart from that, this makes a independent risk factor, which has nothing to do with already existing risk factors. Let's talk about the offspring of the women with gestational diabetes show increased adiposity and adverse cardiometabolic profile and earlier onset of the puberty among girls. Increased fasting glucose and HOMA-IR. HOMA-IR is a measure of the insulin resistance. HOMA-IR levels among the offspring of the mothers with GDM may be explained by the programming effect of hyperglycemia in pregnancy. So what exactly happens here? Once a mother is having gestational diabetes, how does it affect his adult offsprings? Obviously, the gestational diabetes or the pre-gestational diabetes, both kinds of the mothers are having the chronic insulin resistance, beta cell failure, dyslipidemia, higher level of the inflammation and endothelial dysfunction, which gives rise to the type 2 diabetes, cardiovascular disease, metabolic syndrome, obesity in next generation. So maternal nutrition plays a very important role here. The goal of the nutrition of pregnancy is to support maternal, placental, and fetal metabolic needs, and it may be the first introduction to a lifetime of healthy eating. And this would be a first introduction to the lifetime of the healthy eating for the fetus also, because fetus also starts getting the healthy habits of eating in utero also. What has been seen? Of course, if we all know that poor maternal nutrition may give rise to the type 2 diabetes for a mechanism of action, what is being seen here. We all know very well before that if a mother is taking more of the food intake, more of the food expenditure is there, then neuroendocrine, pancreatic, skeletal muscle and adipose tissue dysfunction will ultimately give rise to the type 2 diabetes. It is easily understood. It is easily understood that more food intake will cause the more obesity, more insulin resistance, more of the adiposity, and ultimately more chances of the type 2 diabetes will be there. But very few of us shall be knowing that poor maternal nutrition, low birth weight child is on the higher risk of getting type 2 diabetes because his body responds rapid postnatal growth. His body has got the increased appetite in early postnatal life because of what the child which has been born with the low body weight, low birth body weight, he will be having more gain and faster gain in his weight or her weight because of the altered leptin synthesis and secretion increased by the visceral adiposity. And ultimately, this will also lead to the peripheral insulin resistance, which will stop the utilization of the glucose in the peripheries, ultimately ending up with the type 2 diabetes. Very important and very eye-opening study, which is showing you the cumulative risk of type 2 diabetes at the age of the 24 years, which has been correlated with the third month glucose level, which has been maintained by the mother. What we call to maintain in our gestational diabetes patient, what we say that pregnancy, our mothers should maintain their blood glucose level. We say that it should be maintained less than 120 at any time. But you see here in this graph, in the third trimester of the pregnancy, the mother is maintaining her glucose level less than 120, still 8% of the offspring at 24 years shall be having on the risk of type 2 diabetes development. So you can understand the problem is so difficult to handle. And we can really do it if we can control the glucose level in the pregnancy time. If a mother is maintaining the third trimester glycemic level between 120 to 139, 19% of the offspring will develop type 2 diabetes at the age of 24 years. If the mother is maintaining her glucose level in the third trimester more than 140, then 30% offspring will develop the type 2 diabetes at the age of 24 years. But if it is more than 200, then the risk is very, very high, and 51% offspring will develop type 2 diabetes at 24 years. You can understand that how much is gestational diabetes in contributing in the explosion of diabetic population. If our country is moving towards becoming the diabetes capital of the world, then definitely this GDM is contributing a lot, and 51% contribution may be coming from the gestational diabetes, because a number of patients, number of mothers are carrying and keeping their glucose level in their pregnancy 200 or sometimes more than that without taking care of that. So this is the level which should be maintained in the normal pregnancy. Fasting plasma glucose should be between 80 to 90. Postprandial glucose should be between 110 to 120, and that comes that mean plasma glucose must not be more than 105. It should be in between 95 to 105 milligram percent. And that is the glucose level. If we can follow this throughout the pregnancy, then birth weight will be between 2.5 to 3.5 kg. And this will be a step to prevent the offspring developing diabetes mellitus. Let's see what is the heart of the matter. Preventive measures against non-communicable disease should start during intrauterine period and continue throughout life from early childhood. GDM offers an important opportunity for the development, testing, and implementation of the clinical strategies for diabetes prevention. Gestational diabetes has also been seen have been prevented by the lifestyle intervention. Finnish study has shown that moderate individualized lifestyle intervention reduced the incidence of gestational diabetes by 39% in high-risk pregnant women. These findings may have major health consequences for both the mother and the child. Apart from that, there has been another study in the South India which has shown that 94% of the GDM cases can be handled very well by the diet and nutrition management only. A very important information which comes out from these studies that lactation at least for 6 to 10 months may lower diabetes risk after the gestational diabetes in the offspring. Breastfeeding for the first 6 months protect offspring developing type 2 diabetes also. So what is needed actually? The timely action should be taken now in screening all pregnant women. For glucose intolerance. Achieving euglycemia in them is important. And not only achieving euglycemia is important, ensuring adequate maternal nutrition so that the child may not born low birth weight, child may not born with macrosomia. Both the condition will depend upon the good maternal nutrition. It is not simply making the euglycemia by using the insulin. Until unless the maternal nutrition is not good, the things are not going to be improved in the future generation also. It may prevent in all probability the epidemic of diabetes. Thank you very much. This we have really done in our RSSDIUP village project, in which we have adopted few of the villages in which more population of the diabetes was there, and we are taking them that care of the, we are explaining them how to take care of their glucose level as well as their blood pressure during the pregnancy and out of pregnancy also. So these are actually required things which should be done. And thank you very much for giving me this opportunity. If anybody is having any